is Paris Mandy. Today I'm going to be talking about chronic asthma. SE is a 17-year-old female presenting to her PCP for a follow-up eval of her asthma. She states using her albuterol MDI inhaler 3 to 4 times a week over the last 2 months. States she's been short of breath with or without exercises, and also uses Flovent MDI as well, her albuterol for morning, and her morning peak flow is about 300, with 400 being her best. Her biggest fear is getting rid of her cats. SE was diagnosed with asthma at age 7. At that time, she was described as a mild presenter. In the last year, she has been hospitalized twice and presented to the ED at least 3 times, where she's been treated with oral systemic corticosteroids. She is diagnosed with migraine headaches with aura since age 15. Her mother is 47 years old, diagnosed with migraine and hypertension, while her father is a 48-year-old smoker with hypertension and type 2 diabetes. Her brother is 21, who is away at college, but he is also a smoker as well. Then she has a 17-year-old twin sister who is a non-smoker. It's important to note that she is a twin, and it's not uncommon for one of the twins to have asthma. A lot of times twins are born premature, and usually high-risk pregnancies. So the fact that she has asthma and her sister doesn't is not alarming and very typical. SE is sexually active, does not smoke or do any drugs or alcohol. She lives at home with her 2 cats and her parents and her sister. The medications that she takes is Flovent, which is a very low dose of 44 micrograms, 2 puffs BID, and then she has a rescue inhaler as needed. She can take Q6 hours for shortness of breath. She's also on birth control, a beta blocker propranolol, Maxalt for her acute migraine, and then her allergies are to penicillin, and then which she gets a rash. Vitals wise, she's very normal. She does have a mild oral thrush, which is most likely caused from not rinsing out her mouth when she uses her inhalers. So this is something that we will discuss in a patient teaching on how to use the inhaler, how to rinse your mouth in between puffs. Can be heard as a mild expiratory wheeze. She's diagnosed. The triggering effects that she has, or triggering factors, are allergens, viral respiratory infections, irritants, extremely cold or extremely hot air. Sometimes exercise can trigger a reaction as well. So the airway inflammation is increased mucus secretions with the airway wall, edema, smooth muscle hypertrophy, and inflammatory cellular infiltrate. So you're going to have your increase of eosinophils, neutrophils, mast cells, lymphocytes, basophils, and macrophages. Risk factors: air pollution, tobacco, smoke, obesity, pollen, animal dander, and dust mites and mold. Very important thing to remember is that her father smokes as well as her brother smokes, and she's probably lived with her father for at least 17 years, and he's been smoking at least that time. Non-pharm treatment, she can do the Global Institute for Asthma, GINA, have some recommendations, and they have a system stepwise approach for asthma treatment. You can see the charts here. SE is around step 4, so she's going to add a medium or high dose of the ICS and long-acting beta antagonist, and she can also discuss an oral steroid as well. And this recommend. So currently she is on Flovent, Proventil, but she needs to change this because this is not working for her. So it's recommended that she add a inhaled corticosteroid such as Qvar Pulmicort. She can combine this with a long-acting or a LABA, so Salmeterol. She can still keep the albuterol treatment as needed. She can add maybe a short course of oral steroids like a prednisone 5-day pack, which just help with the initial asthma exasperation that she's experiencing right now. And also she should avoid NSAIDs if all possible. The goal for treatment is to achieve good symptom control, minimize future risk of exasperations, fix airflow limitation, and watch the side effects of treatment. Open communication between the provider and the patient is crucial. The provider wants to have a good rapport with the patient to help them focus on how to avoid the allergens and manage their own asthma symptoms on their own. So the treatment for asthma is adjusted on a continuous cycle. So you may prescribe one thing, monitor it for 3 to 4 months, see if it's working, see how well it's working. You can taper down, you can add, but it's constantly as a continuous cycle, and it can various reasons in life where you might want to add more inhalers or come down, maybe through a stressful time period she might need more. If she moves to a different environment she might need more, but then you want to have good asthma control at least for 3 months before you start to change some of the medications or decrease down the medications. So follow a written asthma plan, and definitely follow up with your primary care doctor. And these are my references. Thank you for listening to this presentation.